Hi, it's Dr. Centeno, and thanks for joining us. I know we'll probably have people join us as we go here. I am just going to post the blog that we're going to be discussing today, and our topic is: can you have a serious neck injury, one that's going to cause a lifetime of chronic pain, and still have a normal neck MRI? And this is a big problem for people because many times they'll get into a car crash or something will fall on their head or some other trauma will happen. Or they've got chronic neck pain and they'll get an MRI and it comes back either normal or just with something like degenerative disc disease that doesn't really explain why they have chronic pain. So they're left in this limbo, if you will, of my imaging doesn't really describe why I hurt, doesn't really provide a convincing diagnosis that someone can use to help me get better. And one of the things I wanted to bring up in the blog today was, or this morning, were some of these images that I'd like to review with you, because there's no better way to see the problems with modern MRI imaging than to see what something looks like in actual fact, if we could slice the body open and look at it, versus what it looks like on an MRI to the doctor reading the MRI. So these are some studies that were done in actually the 1990s by two Australians, Taylor and Twomey. And Taylor was training to be a surgeon, but ultimately went into academic anatomy. And Twomey was a physiotherapist or a physical therapist who actually did some research with him, and they developed this technique to be able to take patients who had died of blunt abdominal trauma, meaning they didn't die because of a neck injury. So they were able to actually go in and do cross sections like the one you see here of the C1C2 facet joint, and see what was going on in the neck. Now, these were patients where the pathologist that performed the autopsy said there was no neck injury, there was no neck issue, but they had died of, let's say, a burst spleen in a car crash. So they had the ability to go look at these necks. Now, initially, they expected to find not much or nothing because, again, there wasn't really a neck injury here. But what they found ultimately, and what they published throughout the 1990s, were these really beautiful images that showed all sorts of what are called occult injuries, meaning injuries that are hard to find. So in this case, what they did is, this is someone who had died, again, of blunt abdominal trauma. And then they were able to identify here towards the back part of the C1C2 facet joint. So the dorsal root ganglion. So the dorsal root ganglion is the sensory nerve that would take pain signals from the head. And in this case, you see this beautiful C1C2 joint. You see the cartilage here, which is nice and white. But what you see is a lot of blood in that joint. And then you see a bunch of blood behind the joint. And in this C2 dorsal root ganglion, you see this red spot, which indicates that there was damage to the C2 dorsal root ganglion and blood in that C2 dorsal root ganglion. Now, that can cause a lifetime of headache pain, but I want you to see what an MRI, this is a modern 1.5 Tesla MRI, looks like of that same exact area. So here we see C1, here we see C2. This is the joint. We don't really see the cartilage, so to speak, in there at all, or very little of it can be seen on a modern MRI. We do see the C2 dorsal root ganglion back here, but there's no way we'd be able to tell if there was a little spot of blood in it. In fact, this pixelated smudge. So I'm going to go and show you two other examples of injuries. Thank you so much for asking questions. You could, again, ask your questions about what we're talking about here, or you can ask your question about anything, not on this topic at all. So once I get done with the didactic portion of this, I'll go and start answering questions. So getting back to what we were talking about, if you've just joined us here, is this beautiful section done by Taylor and Twomey in the 90s of the C1C2 facet joint. You see that right here. We also see blood in the joint. We see damage to the dorsal root ganglion, which can cause a lifetime of headaches. And then we compare that to a modern 2022 MRI image, where the C2 dorsal root ganglion looks like a smudge. So the idea that we could detect some sort of injury in here that could cause a lifetime of headache, as is very easy to see here, it's almost impossible to do on a modern MRI. And God forbid if this were an upright MRI, this is a closed bore, lie face up in a tube MRI, the detail would be even worse than you're seeing here. This is a 1.5 Tesla MRI, which is about twice the detail of an upright MRI. So then we get into disc injuries that Taylor and Twomey talked about. So this is a disc here. So there's a neck disc. This is the C4-5 neck disc. This is the C4 bone up here. This is the C5 bone down there. And in the front here is the anterior longitudinal ligament. And then we see the disc annulus, which is the tough fibrous covering. Now, in this particular disc, there's what's called a rim lesion, a big tear in the disc up front here, where the disc fibers of the annulus are torn away from the C4 vertebra. And in fact, there's bleeding that extends all the way in through the anterior longitudinal ligament here. So you might think, okay, well, it's a bigger structure than that little nerve. So maybe we can see this really, really well on MRI. So again, this is a modern 1.5 Tesla MRI, and this disc rim lesion is represented by this little faint white part here. That's it. That's all we see. We can't see any of that bleeding in the anterior longitudinal ligament. And there's a 99% chance that this either would not be read out at all on the average cervical MRI report, despite how nasty it clearly looks here. Or if it was, it might be read out as degenerative disc disease rather than an injury related to trauma. So you're starting to see that while the body has this beautiful detail and these injuries look really bad, and that this one in particular can cause instability at C4-5 and retrolisthesis of 4-on-5 in extension, but detecting it on an MRI is near impossible, or at least would take a very, very trained eye that would have to be coordinated with physical exam, and you wouldn't be 100% sure that that's what you were looking at based on this image. And then finally are these facet joint injuries. And when it comes to these beautiful images put together by Taylor and Twomey, these are the facet joints, which are small joints in the neck. They're about the size of your finger joint. And there's 2 at each level. And what he detected was lots and lots of facet joint injuries. This one has a little bit of bleeding into the joint. This one, the joint is full of blood. This one, the joint actually has a cartilage injury that extends a little bit into the bone. So you see these pretty images. These are 3 different images that show damage to the facet joint. And these slides were taken in the 1990s. But now I'm going to go to what that looks like in the real world today in a 2022 MRI. So those beautiful joints up here where we can see the cartilage, we can see the blood inside the joint, we can see a clear break in the cartilage here, is represented on a modern MRI by this smudgeogram. And a smudgeogram is medical terminology for the image is just not that clear. I can see where the joint is, it's here. I can see the bone that makes up this joint. I can barely see the cartilage as maybe this little gray line. But if there were blood in this joint, the best I could say is maybe the joint had some swelling. Or if there were cartilage damage and bone damage to this area in here, like there is up in here, if anything, it's going to be a small little pixelated speck. So it's unlikely to be read as a facet joint injury happening due to trauma. So I'll wrap up my lecture part of today, which is really just about the fact that there's an awful lot of damage that can happen that can cause chronic pain. In the case of these facet injuries, this is where those facet joint injuries refer to. So if you got a 0-1 damage, it's going to refer headache pain here. You can see C1C2 and C2-3 and C3-4 for neck pain, and C4-5 for neck pain, and 5-6 for top of shoulder, and 6-7 for upper back. So all of those different damaged joints can cause chronic pain in these areas. But at the end of the day, this is all we got to look at as the doctor. And again, if this were an upright MRI, the detail would be half of what we're seeing here. This is a closed bore 1.5 Tesla MRI. So anyway, if you get frustrated at times where people are just telling you they don't see anything on your MRI, realize that part of that is because they're not looking close enough. But part of that is also because the detail, even in 3 Tesla machines, meaning the best ones we have on the market, just isn't there to convincingly make a lot of these diagnoses. So this is the blog we're discussing. You can read more about this on the Regenxx.com 2X's blog. And that's this morning's blog. So let me go to questions now, and then we'll just take it from there. For PICL, what would be the difference in outcome if PRP is used compared to BMC and PRP together? We don't generally use PRP for PICL, so there's no comparison I can provide to that. The reason why we don't use PRP for PICL is simply because at the end of the day, PRP has a lesser impact, although still a pretty good impact, on getting ligaments to heal. So if we're going to go in through the front and take the risk of doing that, we want to put our best foot forward. So we generally don't do PRP with PICL, so hard for me to give you a comparison there. Trenton, I've come across concern that stem cells cause cancer. What's your take? Yeah, Trenton, not even close. So let's see here. We published the world's largest paper on that. So let's look at that paper. So this is the Regenxx blog that I was talking about. So if you click up here, you can go to the blog. And this is this morning's blog we talked about. Now, if we go up here into physician resources and we go into published research, sorry about that. So if you click on published research and we go down to, I think it was 2016, but that's my best guess. Here it is. So multi-center analysis of adverse events amongst 2,372 adult patients undergoing adult autologous stem cell therapy for orthopedic conditions. So this is the world's largest paper on that topic ever published. The second largest would be a paper by Hernegal, which is about 1,800 patients. Now this was 2,372 patients where we looked at all adverse events, including cancer and the frequency of cancer. Hernegal focused only on cancer and has 2 different papers on that, but studied fewer numbers. But the bottom line from this paper is at the end of the day, there were no increase in cancer rates in any of these patients that were treated with bone marrow concentrate, which is what we're talking about here, or even culture expanded mesenchymal stem cells. So not a thing based on the largest paper on earth that's been published to date, which we published, as well as the second largest paper published to date, which is 1,800 patients, published by Philippe Hernegal in France. So yeah, not a thing. I think you're talking about theoretical risks if you were to try to grow the cells too far, or if you're using embryonic stem cells where you can get these bizarre teratomas, but not with regard to what we're talking about here. Trenton, has your clinic been reviewed by an IRB? Do you have an active IND application? A little bit different here, Trenton. So we're talking about, let's take that in 2 parts. The first would be an IRB. We have an IRB on our registry. and we do lots and lots of research. So all of those research protocols go through IRBs. So let's go back to the website here. This was the published research we've published on what we've done through the years. But if we go under physician resources and go to clinical studies, you can see our open clinical studies there. So these are our open clinical studies. So those would obviously all be under an IRB. When it comes to IND application, we're talking about a surgical procedure that uses autologous cells. So there wouldn't be any IND, meaning an IND would be if we were, let's say, using culture expanded cells, that would require an IND. So our culture expanded cell technology, for example, is part of a phase 2 FDA clinical trial, because that would be a drug. Or we have another drug candidate, which I can't talk about right now, where an IND is being readied. So we are trying, in that case, to produce a drug. So that's what an IND is for, is to do clinical studies on a drug. When it comes to a surgical procedure, that's regulated by a state medical board, and those terms don't make sense. Let's see, would you share the raw data that you've collected so far on PICL patient outcomes? Trent, I don't think we're going to share that raw data at this point. Certainly the analysis is there. We're due for another analysis here probably in the next 2 months. So my research team will pull that. Not going to share that raw data, but certainly happy to have you review what's on the video, and then we can go ahead and update that pretty soon. Trenton, again, I think you're confused. So you're talking about a surgical procedure. So let me give you an example. A knee arthroscopy. A knee arthroscopy has no FDA approval. It's a surgical procedure. So a surgical procedure would go through the state medical board. So if there's a problem with a knee arthroscopy surgery done in the state of Colorado, the Colorado Medical Board gets involved. Now, there may be FDA approved devices or even drugs that are used as part of a knee arthroscopy procedure. So let's say the knee arthroscope itself is a device that would have a 510(k) approval through the FDA, meaning a device type approval. When it comes to a steroid injection, that's a drug that you can pull off the shelf. So that would have its own FDA drug approval. And those approvals don't really have much to do with insurance approval. Now, with regard to Regenxx and the procedures we perform, which aren't drugs, we do have 500 companies that cover all of these procedures, including the one you're talking about. And we add about 100 to 200 companies a year right now. So as far as when that goes to 1,000 companies or 2,000 or 5,000, that's a good question. But right now we're at about 500 companies. We expect to be at around 700 companies by the end of the year. How many people are covered there? Getting close to 1 million, somewhere in that range. So let's say we have close to 1 million people who have coverage in the US for everything we're talking about up here. Centeno Schultz, submitted advanced by Harry Winston. Fascinating blog. After reading it, it occurred to me that perhaps cervical should be an entirely new and separate specialty. Yeah, Harry, it is interesting. What's really interesting to me is to see the incredible detail of what it looks like in real life. So let's get back to that blog. This amazing detail that Taylor and Twomey are able to capture, and the techniques that they developed to be able to cross-section these autopsy specimens versus, just the stuff that we have to see and look at on MRI. I mean, the difference is literally like, a modern digital 35 millimeter camera, the best in the world, versus what we used to have to put up with way back when in the 1990s when you took a cell phone picture and it was this kind of weird pixelated thing. So it's a little frustrating to see the difference there between the two. Shanza, Hedrick Centeno, could you guide us to some studies that talk about PRP restoring the original consistency of a ligament or shrinking and tightening it? Several studies talk about thickening of the ligament under PRP. You had also alluded to thickening. Yeah, I think we had this discussion last time, Shanze. It's important to note that when it comes to a ligament, we're not really talking about thickening as much as we're talking about strengthening. So a normal strong ligament, and same thing goes for a tendon, is tight and compact. And as that ligament gets weaker, it gets bigger and bigger and bigger. So the terminology we want to use is, can we strengthen a ligament or a tendon using PRP? But the size usually goes the other direction. So let's see here, and I haven't searched for this one in a long time. Let's see here. There was a study I may have talked about last time, but let's see. Yeah, I can't find it right now. But anyway, long story short is there was a study that was published that showed that injecting PRP into human Achilles tendons, and this is the rare study where these were live patients, and they went in, they took a tendon biopsy after the fact, which is really hard to do. It's amazing they could get that one through IRB approval, because you're having to go in and do a little bit of damage to the tendon after you've injected it. But somehow they did, and they saw a significant improvement in the collagen that was produced. Now, when it comes to restoring consistency of a ligament or shrinking and tightening it, in the cervical spine, I think I'm the only person that's done that study. And it wasn't with PRP. It was a long, long time ago, using prolotherapy, and it showed significant reduction. Let's see here. The problem is cervical also brings up pelvic, so can't do it quite that way. Let's try this. That's not going to help us. Here it is. So this is a study we did a long, long time ago in 2005. That's almost 20 years ago. And what we did is we looked at the amount of motion on flexion extension X-rays between vertebra. We then went ahead and injected the supraspinous and interspinous ligaments back here using a prolotherapy solution. Then we went ahead and blinded those films pre and post, had someone read them, and what the blinded reader determined was that there was decreased motion and translation between the vertebra, meaning that we were tightening the ligaments as a result of those injections. So I think that's the only study that's ever been done on tightening neck ligaments. At least if there's another one, I haven't seen it. That doesn't mean it's not out there. It just means I haven't seen it. So hopefully that answers your question. Rachel, will you please link to this paper so we could reference their work when meeting with uneducated docs? Oh, Taylor and Twomey. Sure. Let's see here. So I actually looked at that this morning. There's a bunch of papers. It's actually, there's also a great book. So this is the book, and it's still out there. You can't get it on Amazon anymore, but you can buy it directly from Elsevier. This is the book that they produced. It's got all those fantastic images in it. There's also scientific studies, which I think we'll find here. Yeah, so I will copy and paste this link, which goes to PubMed. Hoping that works. I think it worked. Let me know if you can see that on your side. Looks like you can. And that's the link to all the different Taylor and Twomey studies that were published in the 90s that made it into the blog. Brendan, for neck MRI, got an upright MRI and was told by your office there was no measurement of the alar and transverse ligaments. What kind of measurements are you guys looking for? Also, yeah, the MRI is so fuzzy, I don't know anyone's supposed to see anything. Yeah, Brendan, you can see the frustration sometimes amongst doctors that are trying to look to find where the injury is. As far as measuring the alar and transverse ligaments, so as you might imagine, you saw how fuzzy those things were. As you might imagine, if we try to do the same thing for alar and transverse ligaments, they're also a bit fuzzy. And so looking at the structure of the alar and transverse ligament can be challenging. And in an upright MRI, that's going to be half or a quarter of the resolution of a 1.5 Tesla or 3 Tesla closed bore MRI, the one where you're lying face up in a tube. So we generally don't use that method. What we will use is looking for extra motion. And that extra motion is actually this study. See if I can find it. Yeah, so that's the study. And that uses what's called digital motion X-ray. Here, it's called video fluoroscopy. But the bottom line is, this is the study that looked at the normals versus abnormals for that motion. So we're looking at alar transverse ligaments. We'd be looking at what's called digital motion X-ray. And that's a live moving X-ray where then a video is taken. And we're looking for things moving too much to indicate that the ligament has been damaged. So that's how we do that. Now, an upright MRI with flexion and extension, there are definitely things that we can see there. So, for example, if we look at the Grab-Oaks measurement, so a Grab-Oaks measurement, actually this is off one of my YouTube things. The Grab-Oaks measurement is how far the dens goes backwards. Now, in flexion, we can sometimes see that dens move further backwards. So that would be an indication of a loose transverse ligament. So if there's flexion extension with the upright MRI, we can certainly use that to try to see if we can see that. But if you had to place a bet out of the gate before you looked at all the pictures on which of the two technologies, the DMX or an upright MRI with flexion extension, would be more likely to reveal a CCI diagnosis if it's there, you'd win that bet if you bet on the DMX more often than not. Now, that doesn't mean that the upright MRI might not show it. It just means the DMX is more likely to show it. Dr. Centeno, what do you think of medical gaslighting that many have experienced years before finding your clinic? How does one push back against docs who refuse to budge? Yeah, Rachel, that's a really great question, and one that I have to say I'm a bit embarrassed about, being a physician. Meaning at the end of the day, maybe medical gaslighting is not the perfect term, but at the end of the day, we have a lot of physicians who know what they know and don't know what they don't know, right? There are things that you know. There are things that you don't know. And then there are things that you don't know. And it's that third category that gets really frustrating for patients because they go to a doctor who doesn't really understand this area that we're talking about right now. And they may be very, very good within the stuff that they know. And they know there's certain things they don't know. But what they don't fully understand is all the stuff they don't know. And that's really, I think, what you're talking about. So now I think you're going to meet two kinds of doctors out there, right? You're going to meet one kind of doctor that says, I bet you there are things I know I don't know, in which case I should learn more. Or you're going to be the kind of doctor that says, I know pretty much everything there is to know. I know what I know, and I know what I don't know. Hence, if this doesn't fit into one of those two boxes, it doesn't exist. And I think that's the thing that you're talking about, and it's extremely frustrating for patients. So I apologize on behalf of my profession, but it's quite common, meaning that instead of being taught the right way, which is, hey guys, You do not know everything walking out of medical school, residency, or fellowship. And there's going to be new stuff all the time you're going to have to keep up with, which is what we were taught coming out of medical school. Many times doctors get into this place where they just believe they know it all. And obviously, as you've seen, they don't. So I think that's what you're talking about. And it's very, very frustrating for patients. Tamara, I'm fused C1C2 and I'm experiencing movement rotation at C0, C1 and neurologic symptoms. With PRP, help me. I have reverse curve from C3 and collapse 5-6. With PRP, help me at all. Thank you. You know, Tamara, that's a difficult place to be. We have a collection of patients who have had a C1C2 screw fixation fusion. And those patients in general are tough to treat. Now, we have been able to help some of them by doing things like treating, let's say, a 0-1 facet joint that might be damaged or on fire. But as far as the same types of benefits that a non-fused patient might get from the PICL procedure, that's generally not something that's going to happen once that ship has sailed with the C1C2 fusion. So again, doesn't mean we can't help you, but we could have probably helped you more before the fusion than we can help you after the fusion. Or again, if we're just talking about likelihoods, that's the likelihood. So just realize that always happy to take a look to see if we can help. But after the C1C2 fusion, it gets a bit more complex and more difficult to help. Centeno Schultz, submitted advance by Madeline White. Thank you for educating us on this issue. Do you lecture at medical conferences as well? Is this a test that produced the 1985 image still available to the general public? Yeah, so I lecture all the time at various medical conferences. There's 2, I think, coming up in May. I usually blog on where I am at those conferences. So one of those, I'll be talking about this topic, and in fact, including some of those tailored Twomey slides. Now realize those are post-mortem slides. So what that means is that the patient died of blunt abdominal trauma, and then they were able to take the neck, freeze it, and then section it, and then put that in wax so that you could look at the section. Now, sometimes they've used various stains to bring out certain things, etc. But realize that's not a technology you can use in living patients, and that the type of imaging you're seeing there is just a real life representation, because that's how it really looks if you could saw it in half. And obviously the only way you can saw it in half is the patient's not living, because you have to kill the patient to get that kind of image. Now, might we one day have imaging at that detail? We may. There's a 7 Tesla MRI that's currently on the market. It's mostly being used in universities for research purposes. And we may have even better technologies 20 or 30 or 40 years in the future, where we can see at that amazing level of detail that Taylor and Twomey got to in the 1990s, but not available for living patients for obvious reasons. Brendan, oh God, yes, I'm frustrated by MRIs, ligaments are so small. Yeah, Brendan, I wouldn't feel hopeless. There are other ways to skin that cat and try to get to a diagnosis, but it does mean that it takes more time, energy, and effort and expertise to be able to try to direct where the care should go based on imaging. But yes, I share your frustration. You can see the difference there. The difference is so stark that you're like, wow, I'm amazed at the junk, if you will, that we have to look at. You know, these are $1 million, $2 million, $3 million machines, and they are massively better than not having an MRI. But you can see they're still a long way off from being anything close to perfect. Justin, my symptoms came on after a neck trauma in which I heard a loud crack from the base of my skull. I had a DMX that shows some instability in MRIs that show some scarring of ligaments. Would you recommend further imaging to make sure that nothing else is going on? You know, Justin, I think that's probably fine. Again, I'd have to look at your specific set of circumstances and all of that, and that has to be combined with a history, has to be combined with a physical exam, and then it responds to treatment. So imaging, history, physical exam, response to treatment are the ways that we get to a diagnosis. So imaging, as you've described it, is probably pretty good, certainly good enough for us to start trying to add in those other things to see where that diagnosis meter points to. But it's got to be all of those things combined to get to a diagnosis. Do you believe there will be advancements in imaging that allow patients with neck injuries to get more accurate diagnosis? Yeah, Justin, we were just talking about that. And yes, I do. I think the biggest advance in medical imaging that we'll see in the next 10 years will be the use of artificial intelligence in imaging. And what I mean by that is that when we look at these images, there's massive amounts of electromagnetic data that's generated by the MRI scanner. But taking that data and trying to make it into an image that a human can look at is a super inefficient way to try to get to a diagnosis. In fact, it would be far more efficient if you could train artificial intelligence systems to look at the raw data and then associate the patterns in that data with actual diagnoses. And I think we will see that. I think the first thing we'll see is that many radiologists will be out of a job, meaning that we'll see more and more machine reading. And then at some point, some smart people will start looking at the raw data and associating that with certain treatments or certain diagnoses. And taking the human out of that mix probably will be incredibly powerful. So that's probably the next step before we see the kind of detail you can get on postmortem slides like we saw in Taylor and Twomey. Justin, what about issues with blood flow from venous or arterial compression? What's the best imaging to detect those types of issues? Yeah, Justin, I put those into two different categories. One is, do you need that imaging at all? Meaning, is it going to help? So we know that if you, for instance, got an internal jugular vein compression, and there's actually a blog on that. So let's see if I can pull it up. So let's go to internal jugular vein and search that on the blog. Here we go. So this type of imaging here, where you have a CT venogram, can certainly be very, very illustrative of a problem with the internal jugular vein or venous compression. So this is the internal jugular vein coming up here. This is the front part of C2. And you can see on the good side that this vein is nice and wide on the right, but that the vein narrows up top here. And that's occurring due to instability. And so getting an image like this is not always so easy. In addition to that, this is a CAT scan. And in a CAT scan, we're exposing the patient generally to about 100 times the amount of X-ray that they would be exposed to in a chest X-ray. So it's a lot of radiation. So the first question you have to ask yourself is, do you need this image to treat the patient? And the answer is usually no. Now, if you've treated the patient with something like PICL, which is non-surgical, and you're still running into issues, then getting an image like this makes all sorts of sense, because that might help localize, let's say, a specific surgery, etc. But I think the first thing is probably to treat the patient and then expose the patient to all this radiation if they don't respond. So this internal jugular vein, and this is a CT venogram or a CAT scan venogram. It's got to be done by centers who understand this stuff and know what they're looking for, but you can get this kind of information from it. You can also do ultrasound of this, but it's not quite this pretty, and it's a lot more operator dependent. So that means that teaching a tech to do this would be easier than teaching a tech to use ultrasound to find this kind of compression. But since this is due to instability, it makes more sense to treat the instability before you expose the patient to 100 chest X-rays of radiation. Rob Carling, I'd actually last week you mentioned use BMC with PRP. Is that at the same time? A Regenxx doctor is having me come back a week later for PRP for my hip. Yeah, I think what you're seeing there, Rob, is that when we use bone marrow concentrate, really any use, whether it's for a neck use or a hip use, we're adding in PRP or platelet-rich plasma to that bone marrow concentrate at the time of that bone marrow concentrate injection. Now, in joints like the hip or the knee, there is a protocol where you perform a post-injection with usually PRP and platelet lysate afterwards as sort of a fertilizer shot. So I think that's what you're seeing here is your doctor is using that protocol, and that's more of a fertilizer shot. But when BMC is injected initially, PRP goes with that BMC. So both of those were injected, and then you're getting a follow-up shot with PRP and platelet lysate. Stevie Ann Williams, I smacked my head on a kitchen cupboard. Sorry about that, Stevie. I stood up and hit the back of my head really hard. Yeah, that's the worst. I've done that a couple times. Could this cause similar injuries to whiplash and potentially cause CCI and AAI? Well, as someone who has done that himself multiple times on everything from, getting out of a car to things you just didn't see, and I'm sure there's a lot of us on here who have done that at one time or another in their life. It can be a pretty hard hit. And the thing is, you're not protecting yourself for the hit because you don't know the hit's going to happen. So is it possible that could cause a stretch injury to the ligaments that hold the head on, or CCI, craniocervical instability? The answer is yes, it can. So that's a possibility for sure. Now, is that a super common one in CCI patients we hear about? Less so. I would say the most common CCI causes that we see out there are a car crash or HEDS or hypermobile EDS with or without an injury. Another one would be something that hit the head. Another one sometimes is a high velocity manipulation of the neck. I have heard of injuries like this, but they would be less common. Doesn't mean it didn't cause CCI. It just means that in all the different matrix of things we hear that cause CCI, that's less common. Stevie, can someone with CCI and AAI have the measurements diagnosing them but not have any symptoms? Sure, and it's one of the things we've got to be really careful of when we look at all of this, because we have to make sure that the person not only has, and that's why I was saying before, that we need to look at the history, so symptoms. Do the symptoms match CCI? We need to look at the measurements. Do the measurements match CCI? Response to treatment. Does a cervical collar help, or does injecting the upper neck help? Or does the patient crash and burn with active physical therapy? Those are all responses to treatment that are pathognomonic. And then finally, we've got to look at hands-on physical exam. And does it localize to the upper neck, which is where CCI injuries would localize? So we've got to look at all those different things. Now, if someone just has extra motion on an MRI or a DMX, it's hard to know whether we should treat that person. We certainly shouldn't do surgery in that person, that's for sure. And I would say they shouldn't even get a PICL treatment, because until we have much more data on PICL, we've done it 600 times or so, but I'd want to see 5,000 patients deep of data without any serious complications before I'd recommend treating someone prospectively or proactively. So I would say if they don't have symptoms, then no treatment that breaks the skin. You may try physical therapy, you may try upper cervical chiropractic, that kind of stuff. Levon, is clicking during motion, flexion, extension, and cervical spine normal, or does that indicate instability? It can be normal, and it can indicate instability, meaning that we all hear these, I can't do it really well, but some people, they can crack their knuckles. They're cracking their knuckles because that's what's called joint crepitus. So there are little air bubbles that form in the joint, and when you do that, it presses on the air bubbles and it makes those cracking noises. So the question is, are you having normal cracking or cracking due to degenerative disc disease? Or is the cracking you're hearing associated with instability? Now, if it's associated with instability, normally it's either painful at the time or painful later. So I would say if you've got cracking and then pain, that's something we want to take a closer look at, or cracking and then symptoms. But if it's just your neck cracks, I'm not sure I'd be so worried about it. Barbara, how long after getting PICL procedure is safe to fly home? Yeah, Barbara, we're really looking there at being dependent on whether or not it's the first time or a subsequent time, and how far the patient is traveling. So the most we would say would be a patient who's a first time, let's say from Europe coming to the US. We'd want you to be here that whole week. So treatment early in the week and then stay the rest of the week, leave on the weekend, because we're just trying to make sure that that person is absolutely fine to get on a long plane flight to go home. Now, domestic, meaning coming from the US, we can shorten that to, we want you to stay at least an extra day for the first time, and then you can go home that following day. So if we need to see you back in the office, we can. Now, if it's a second or subsequent time domestically, meaning you're coming from the US, and we already know how you're going to respond, and you didn't have any big issues with tolerating PICL, then you can generally go home that next day after the PICL, as long as you feel safe to travel. And obviously, if you don't, we're happy to write you a note. These days, perhaps the only good thing about COVID, as you know, is that many of the airlines no longer have these crazy policies where you lose your ticket. You can actually now cancel a ticket and get another ticket because of things like COVID. So but you'd have to play it by ear. But most of those people who already know this is not a big deal for them fly home the next day. Levon, how many PICL treatments on average instability case require? So there's a 1 in 5 chance that this is a one and done treatment, and then a 4 in 5 chance that you're going to need between 2 and 4 treatments to get where you want to be. So that's on average how this goes. PF, DMX is not available. Could you give some recommendations on how maybe you can use normal Xray? Yeah, I think it's possible to do. We've had some patients in Europe who have done that. It's really an open mouth view where we're seeing C1 and C2 from the front, and then bending as far as you can and taking another picture. Now, the pictures aren't always so easy to get because it's hard to have the patient bend their head and keep the open mouth centered on that C1C2. But it's possible to give instructions, and then whether or not they can follow the instructions and get it done is always an open question, but instructions can be drawn up for sure. Okay, and that's the link I posted before. And that's another link. Okay, so let's go to Brandon. Sorry, I'm confused. Rob has told me the MRIs you guys ordered and then I completed is missing measurements for alar transverse from the reviewing radiologist. I don't know what that means. I don't know what that means either, Brendan. It doesn't sound like there's an issue, meaning we read our own films. We don't require the reading radiologist to comment unless there's some specific reason or something that we might be looking for that's very rare. Obviously, we want them to comment on their normal read, but we then do the reads ourselves, looking for more specific things. So why don't you do this? Why don't you write me directly so I can get involved, because that one doesn't seem to make sense to me. I'm going to put the email that goes to my desk down here in the comments. So Centeno office at centenoschultz.com is the email that goes to my desk. So feel free to send me a personal email about what's going on so I can get involved to see what's happening there, because that doesn't make sense to me. Listen, it's always possible that someone didn't get the right memo on the call center side. So reach out to me directly, and I'm happy to get involved and see what's happening. Rob, question. If someone has about 1 millimeter clearance between C2 and the spinal cord, does inflammation after PICL by chance cause a small gap to shorten? Yeah, it's theoretically possible. Let's see what images we can find online. Okay, so see what we can see. It's a good one. I think this is off of our website. So what you're talking about is that this is a flexion upright MRI, and it's a really nice quality flexion upright MRI. You can see it's fairly crisp, almost like a closed bore MRI. So this is a nice image. And we see here at the back of the dens, and the back of the dens goes into or closes this gap between the brainstem and the upper spinal cord. And so that is called lots of different things. One of the things it can be called is a cervical medullary syndrome, meaning cervical banging into medulla, which is what that's called. Now, if that's very close in neutral, it's possible that swelling in this space could push out on this area temporarily for the first, let's say, 3 to 7 days before that swelling starts to resolve. So it's possible that that could cause some extra symptoms during that time, especially if there's not a lot of room there. Now, every time I personally think that that could be going on, I see cases where that's there and we don't see any of that. So, it may be due to other things, but I think that's a reasonable question to ask for sure. Adina, can CCI determine vertebral basilar insufficiency? If no, can PRP or PICL help with that? Can CCI determine vertebral basilar insufficiency? I'm not sure what the question means as to the relationship between vertebral basilar insufficiency and CCI. So maybe if you could rephrase that. Question, is propofol the only anesthetic used to sedate, or is there an alternative? No, we use lots of different anesthetics to sedate people. If we're talking about for routine spinal injections, that's normally Facet and fentanyl. If we're talking about for PICL, that's usually propofol, Facet, fentanyl. We'll also use glycopyrrate, which is a medication to dry up the back of the throat. And sometimes add in ketamine if the person's really having a hard time tolerating the whole thing. So those are the drugs that are used. Now, as far as skipping propofol, that would be a tough one during PICL because it would be hard to keep the patient asleep. So regrettably, I think that one would have to be used regardless. Dr. Centeno, is there any place in the US we can travel to get a 7 Tesla MRI? I don't know the answer to that one. That's a great question. So let's see. I wonder if someone's advertising for a 7 Tesla at this point. So you see academic centers like the Mayo Clinic. I don't see anyone advertising a commercial 7 Tesla. I think the problem is the cost. Well, here we go. 7 Tesla MRI locations in the USA. Yeah, these are all academic centers. And I would suspect that you can't make it into the 7 Tesla MRI at these academic centers because they're all being used for one research study or another, or perhaps really, really, really fine brain work where they're trying to identify exactly where a tumor is, or diffusion tensor imaging, tractography, where they're trying to do similar things. So I think for all intents and purposes, it's probably really hard to get one of these, but you can certainly call the Mayo Clinic, Harvard, which is Brigham and Women's Hospital, and others like UCSF to see whether or not you can actually get imaged on the 7 Tesla. Because I don't know, but I don't see any commercially available ones where you can just walk in to a commercial site, and that's probably because of the cost. If a 3 Tesla MRI is going to run probably now about $2 to $2.5 million, I'm imagining a 7 Tesla, because they produce so few of them, is another big cut above that. So it's probably not financially feasible, meaning the insurance company isn't paying more money because it's 7 Tesla or 3 Tesla. Levon, I've rescheduled for an MR angiography while I received a summary report imagery to CT scan Venogram you have provided. I'm not sure what you're asking. That was actually a CT Venogram that was done elsewhere. I was just showing you the images of what that looks like. I'm happy to look at the MRI angiography as part of a telemedicine evaluation, or if we've already done a telemedicine evaluation, you can submit it. We can tell you what we see on it. And then as to whether or not the reading radiologist reads that stuff, I don't know. Realize that MR angiography is on the arteries, so it's less likely to show stuff like we looked at in the internal jugular vein on the CT venogram. So there may be some disconnect there. Brendan, when you say internal jugular vein compression is due to instability, would it be due to malrotation of the vertebra, or do you see where the vertebra is aligned properly but still compresses? Yeah, so Brendan, what we're really talking about here, the most common situation would be that there's instability. That instability causes rotation. And I'm going to take you back to the image that started this particular discussion, because that's a good one for that, to understand that. So let's go back to this morning's blog. And if we go back to this morning's blog, we see this C1C2 image here. And in this C1C2 image, we see that this C1C2 joint here is pretty unique in that it's a concave surface on a concave surface. Now, normally joints are the opposite. They're concave convex, right? One part that's concave goes into, so a ball or a shallow ball goes into a socket, and that locks the whole thing together so it doesn't move. But the C1C2 joint is a concave on a concave surface. So if the ligaments aren't doing their job and the muscles aren't doing their job to align that with micrometer or millimeter precision as you move, then one of these is going to fall forward on or backwards of the other. And that's why we see those rotations happening in instability. So the rotation is a function of loose ligaments and the way the joint is shaped. And it's an odd shape. And I suspect it has to do with the crazy amount of rotation that can happen at C1C2, meaning 50% of your neck rotation happens at that C1C2 joint. And I suspect if we were looking at the animal kingdom at like owls that can go 360, their joints look a lot like this, because if you want a joint to do that, you probably have to design it this way. But the downside of this design is that you end up with one bone in front of the other if the ligaments and muscles aren't holding. So that's what we're talking about there. And I think we're getting close to having to end up for today. I'll try to take 4 or 5 more questions. I do have a hard stop and a meeting at 2 p.m. my time, so I'm going to try to take a few more questions here. Rob, why don't you contact me offline on that one? I put my email address below, so contact me offline just because we're coming to the end and I probably don't have enough time to answer that. W.C. Hurst, are dental CT scans helpful to you? Less so. And we don't rely on many CT scans, period. So just realize that, well, if you have one, I would love to look at it and see what I can see off of it. I wouldn't go out and get one because all CT scans, including these type, although these type will have less X-ray exposure, have a lot of X-ray exposure. Stacy, I recently had mouth X-rays, a lot of a bend to C1C2, and there's definitely overhang of C1C2 on both sides. Does anyone overhang and confirm CCI, or does it have to be a certain millimeter amount? Yeah, so that's going back here to this study, Stacy. And I will put the link to that study down here for you. But the bottom line is that we look at 2 to 3 millimeters as being abnormal. So more than 2 millimeters is a 2/3 chance of being abnormal. More than 3 millimeters is a 95% chance of being abnormal. So that's what we look at there on the overhang measurements. And it's based on the study I just put in the comments below, which is the one that's on the screen right now. Phil, in the same way that anti-inflammatory drugs should be avoided post-PRP treatment for several weeks, are there any anti-inflammatory herbal supplements that should be avoided? Yeah, Phil, when it comes to things like curcumin or fish oil, which is the two that we normally look at, they generally work through inhibition of a different pathway, COX versus LOX. So I don't really have too big a concern with some inhibition in the LOX pathway, the lipooxygenase pathway. It's more the cyclooxygenase pathway, the COX. So NSAIDs work on COX, which is a problem. The other guys generally work on LOX, which is not a problem. Rob, with PRP inside of Facet, it doesn't clot up. LOA, just curious how that works. Yeah, so even if PRP were to clot up inside a joint, realize that that's the normal process for anything that happens in the body for healing. You bleed into the area, it forms a clot. The clot provides a biologic scaffold. So if PRP is clotting up inside a facet joint, that's perfect. We couldn't really hope for it much better than that. And wonderful. It looks like I got through to almost all of these. The two people I told to email me, feel free to email me directly. So let's wind this up today. We talked about this concept, which is on the blog. And if you want to read that, go to the blog directly. And that is that there's an awful lot that we're not seeing on really good MRI images. And I tried to give you this morning in the blog some examples of just the differences between these beautiful Taylor and Twomey cross-sectional images that we see after autopsy of what this stuff looks like in real life versus, the smudgeograms that we're many times interpreting on MRI. And I wanted you to be able to touch and feel it in the same way that we doctors have to deal with it. And so I hope you have an appreciation now of how different that is and what a big disconnect there is between those two. So thanks so much for watching, guys. I will be doing this on Friday again across all three channels, Centeno Schultz, Regenxx.com, and YouTube. Also realize that regardless of what I ever talk about, I'm just starting conversation. I'm happy to answer any questions you have because I believe that patients that understand what's wrong with them at a gut level and they really understand it intellectually are just easier patients to treat that are much likely to get better and are much likely to navigate this crazy thing we call the medical care system in our country. So thanks so much and have a great day. And I'll see you on Friday. Same time on Friday. Thank you.